Everybody. Thank you, Dr. Gopal, for including me in your course. Today I'm going to talk about controversies in the management of ROP. Now, I just make a list of few controversies, and some of them have been touched upon so ably by people who have spoken before me, so it makes my task more easier. Now, who should screen for ROP is a burning question, whether it has to be an ophthalmologist, whether a telescreening personnel, certain pediatricians, who can do the initial screening, but the need is the ratification has to be done by a trained ROP specialist with a binocular indirect ophthalmoscope with dilatation, with an indentation of 20 or 30 diopter lens with a depressor. Because can one miss the disease? Yes, if a person is inexperienced, is in a hurried form of an examination is done, obstruction or discomfort from tubes and gadgets while examining, excess light in the NICU, non-dilating or purely dilating pupils, and a very sick infant requiring a hurried examination. These are all the deterrents for a good examination, and you may miss something, like scenarios like this where there are only tubes which are seen around the patient's eye. Now, second controversy is about the dilatation. Dr. Gopal has already told you that the best combination is phenylephrine with tropicamide, and I'm not going to go further into that. And as he also mentioned that the microdropper is a good idea to do it. When you put the drops, you can do punctal occlusion, and you can turn the head of the patient away while putting the drops from the site of the opening of the fornix. And you can use mid-reasserts, lower conjunctival fornix packing can be done. And vaporized tropicamide applications on eyelids margin or phenocaine is another option which you can give topical, which helps the dilatation. The stage 3 is the staging of the disease. There was a study by Campbell et al., and they had reviewed 1553 eyes where they found a whole lot of controversy was there regarding the classification, pre and plus classification, in the zone classification, and in the overall staging. But the only thing which was consistent was that 95% were on agreement on the zone 1 disease. Now, the thing was diagnosing plus or pre-plus. Now, ICROP3 classification still recognizes plus as a continuous spectrum. Type 1 or type 2 definition is still based on labeling the patient as a plus or pre-plus, and there is no guideline as to the management of pre-plus. So what are the suggestions given? If one eye has frank plus, then veer towards plus. If the eye needs a surgery for a systemic indication, treat as plus. Have shorter intervals between examinations for better conclusions. The next controversy is whether it is zone 1 or zone 2. So there are certain characteristics. Now, ICROP3 has included a posterior zone 2, and the presence of that to address several disease states which are prominently in that particular zone. But still, you have certain areas, zones, where you find that it may look like a zone 1 disease or a classic disease, but actually it is, the deterrents were whether there was a notch, whether it was coming into the zone 2, transgressing into zone 1. And the other things were whether it was an AROP versus classic, because there are sometimes patient looks like an AROP, but actually is a classic disease which benefits from a laser treatment. Now, several other types have been postulated. The hybrid ROP, which Dr. Mangadokra has and associates have highlighted, it combines the classic with an AROP affecting heavier babies in zone 2 with a better prognosis. The incomplete vascularization or immature retina is a new terminology which addresses severe forms of type 1 disease like half-zone ROP, where the arcades may not extend beyond 2 diopters from the optic nerve with no definition of the macula. So these are several prototypes of the same thing showing this kind of disease, and you have to determine what you want to do as treatment for these disease. Now, who should treat ROP? Whether it is a trained ophthalmologist dealing with ROP, trained VR specialist dealing with ROP, whether it's a trained VR specialist not dealing with ROP, pediatrician screening ROP, and we know of certain pediatricians even giving injections for ROP, whether it is a resident training in ROP, because we know that there is inadvertent misuse of anti-VEGFs, whether indicated or not. So suggestion is that have a person give the injection, a person who knows how to laser, when to laser, how to adequately laser. So this is about who should treat. So these are certain cases where you have to decide what treatment you're going to give, which form of treatment would work best, whether you want to give a laser anti-VEGFs or whether you want to go in for a surgery straight away. Now, controversies would be where anti-VEGF versus laser is the first choice of treatment. So this also has been covered very well. And the thing is that it is important that you do not give up seeing these patients or just postpone the intervals, because in that interval, you might result in problems. So you have to follow up these patients carefully till you see it till the end. Now, controversies again is what to inject, when to re-inject, when to laser, after injection. When to inject has been addressed already, so I'm not going to go into that. But when to re-inject is another controversial situation, because it depends on the half-life of the drug that you have used. Now, ranibizumab has a very short half-life and bevacizumab has more. So as it was stated that ranibizumab, the need for giving the injection is generally more, the prevalence. And in bevacizumab, many people do with only one injections, but the peripheral avascular retina is more in the bevacizumab group, and the amount of peripheral avascular retina has been seen to be less in the ranibizumab group. So you have to know when to combine the treatment, how to observe, which patient has to be followed up, and if there is reactivation, definitely go and treat the patient immediately. Now, the peripheral avascular retina is again something which I'm not going to touch because Anand has spoken about it very ably and nicely. And the laser treatments, again, one session or multiple sessions has to be decided. How many shots per session, what care to take, what areas to avoid, that is the ciliary vessels, you just avoid those areas. Now, treatment at 6 and 12 o'clock are generally a little more difficult. So all you can do is elevate the chin, use a shoulder pack under the shoulders of the child so that the neck is a little extended. And the thing is, treat from the diametrically opposite portion, because you can shift the babies and the trolley. And you can do it in the incubator also, as you saw Dr. Mangat Dogra doing it. And when to say no to a stage 5 surgery, again, this has been addressed very well by Parijat. Scleral buckle, definitely still an option, as Subhadra has shown you. If there is a falciform fold which is completely stuck, then don't do anything, leave it alone, because the patient uses the residual vision when you rehabilitate for his ambulation. If it is got a pup tent kind of traction, you release that traction with your surgery so that a greater portion of the retina goes back, so it helps in the visibility process. Late referral, if it is completely closed, do not touch it because it's not going to yield anything. If there is a break during surgery, there is a need to tamponade. Yes, if majority of traction is relieved, you go ahead with the surgery as Parijat showed you. And if there is a resurgery, it is possible in 5% cases where you feel a small adhesion is there somewhere, you can just go and release it and the retina goes back into place. And when to rehabilitate? Early rehabilitation is most important, because in a preterm child, there are several areas where the child has to be rehabilitated right from the time that the child is born in the NICU itself. And medico-legal issues. This is one aspect where there is no controversy. It is just document, 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 and treat as per guidelines effectively, aggressively, and early. Thank you so much for your kind attention.
Thank you, Dr. Karobi. I think we have been given the hall 15 minutes late, so we can take 15 minutes more, right? Yeah. So we got 15 minutes for discussion. If there are questions from the audience, yeah, go ahead, please.
One is to Anand sir.
if I want.
that if you leave that peripheral free, how important is to dissect it because they don't allow the retina to settle in the peripheral phase. So how important is that?
So, persistent avascular retina doesn't require an angiogram to diagnose it. Clinically, it can be done. You have to, of course, have the, you need to look for it. So, you will have to depress the baby. It cannot be done otherwise, speculum and depressor. Since it's a majority of the time in the temporal quadrant, just depressing there, one could do it. You will be following up these babies after anti-VEGF 2-weekly or 3-weekly, depending on the protocol of which injection, which drug you've given. So you will also know till where the blood vessels have reached. So that has to be documented on the file. And 2 disc diameters is actually easy to make out once you've looked at the aura. And what we are hoping to come out with guidelines is between 45 weeks and 55 weeks, somewhere midway, you might need to take a decision on whether you can do the laser or not. But the outer limit would be 60 weeks, at which point if there is PAR to do the laser. And this is the consensus that's building up. And as I mentioned, we'll hopefully publish it as guidelines soon.
The only point I would like to add is that between 20 diopter and 30 diopter lens, if you want to depend only on visual observation as to where the vascularity stops, a 20D lens is better. A 30D lens sometimes you may not be very clear. Dr. Parijat, you would like to answer this second question?
So you're absolutely right. If you leave a large frill, it's not going to settle. So it again depends on how much the retina is attached into the periphery. If you've got a good peripheral access, then it's a very good idea to remove as much as possible and let it fall back. Again, it depends on some surgeons. Some like to go from center to outwards. Some like to go from outwards to inward. It depends on that. But if the whole thing is absolutely stuck on the side and you are not able to relieve it, then better not to tatter the whole thing. So it depends. Best to obviously do as much as possible so that traction can be relieved.
Sir, there was one thing which I wanted to mention. You spoke about how to do a fluorescein angiography if you don't have the access. You can resort to an oral fluorescein dye, and instead, if you don't have a machine, then you can just see it with your blue filter on the indirect ophthalmoscope. So it gives you the information, but the documentation will not be there.
And we have recently shown that you can do this on your Claris, you can do on our Optos, so you can do your angiogram even on the adult machines. So there's no, like if you really have to do it, although it's not necessary as said. See, we just need to see is there leak, so you only need to see the late phase. You don't need to see the early phase and choroidal phase and all. What you need to see is the last phase. So that will come if you do it at 10 minutes.
Okay. Yeah, please.
Thank you, sir, for this instruction course. Learned a lot. I have a question regarding stage 5 ROP. Stage 5B, you have done a good dissection, maximum possible. You've done a lensectomy already. You've done a air fluid exchange. How much hypotony is tolerable at the end? And do you do anything? Sometimes the whole complex tends to come forward at the end. Do you go in again, dissect more? Do you put viscoelastic? Do you give more intensive steroid drops post-op? Then how long?
No, so air fluid exchange is not done. Air is just injected into the AC in the end to close the ports. That is the main idea. So hypotony is not there post-op. The ports are closed. If I said if you can do sutureless, very nice because 25G instruments have 25G MV openings are there. But even if a lot of manipulation is there, it's still collapsing, then there's no harm in putting a suture also. So usually it's not left hypotenuse. Eye is not left hypotenuse. And fluid is there behind. Air is injected to help close the ports.
So if the retina is coming forward, that means there is a break somewhere. Otherwise, whatever you open, it will be left open. Very rarely you may have to put some viscoelastic to push it back. But in general, if things are not going back on their own, they're all floating up, that means there is a break somewhere.
There is also a situation where there may be too much of exudative component, where I find sometimes the retina doesn't permit you to dissect properly. Then you can actually drain the fluid from behind, and it allows you to give space, working space. It's not like flattening the retina in rhegmatogenous RD, but it allows you space to work if it's exudative RD. But otherwise, as I said very rightly, the other thing is that suturing is not a bad word, okay? So if you have difficulty in maintaining the eyeball intact, I don't mind. I use 10-0 Vicryl these days because it's absorbable and doesn't hurt the baby as much as 10-0 nylon. So one single stitch of 10-0 Vicryl can close a limbal wound very nicely. Even a scleral wound can be closed with a 10-0 Vicryl pretty well. Yeah, thank you. Yes?
You can do the combined therapy if you post-injection, is it disease specific that we should wait going for laser
Yeah, I think that comes back to what's the preferred guideline. So ideally, we'd want the vessels to grow at least till zone 2 or wait for the current weight to be more than 4 kgs or the postmenstrual age to be more than 48. Each of these have been chosen for basic science reason. 4 kgs because of insulin growth factor causing the vascularization to proceed. 48 weeks because by then fovealization should have happened and technically the periphery should have got vascularized. And zone 2 because the primary reason why you gave injection and not laser in the first place was to protect as much of zone 1 and zone 2 as possible. Now this is in theory. Sometimes the blood vessels don't grow forward. There's especially posterior zone 1 simply remain at zone 1. And that's where the problem comes, whether you will re-inject or whether you will do the laser. So I think the consensus building is re-inject only if there is a failure to response, and that we will define. And in all other cases, follow up and eventually do laser.
There's also a protocol that we have published, and Dr. Dogra also showed that protocol. Now, if you think a priori you want to do a combined treatment because you know that this is a zone 1 disease and he already showed 80% of them are going to need laser. Tapas has also shown that if the rate of growth of these vessels is slow, they will need laser ultimately. And we have also shown on OCT that some of these OCT biomarkers can tell you they'll need laser. Then you give the injection, after 4-5 days the pupil dilate, you can do the peripheral laser and leave the posterior pole and then follow. And in follow-up, if you find that is not grown at 60 weeks or something, then you can add laser posteriorly. But you've already done very good laser in the periphery. Only caveat is if you do laser in baby who's still 26, 27 weeks at the time of your laser or 28 weeks, what we have shown published is that the anterior retina can grow even after that. So while you may have done laser, there can be recurrence because new retina grows because eye is still growing. So you may have to touch up that area also. So the protocols for combined treatment are also published where you still spare the posterior pole.
I think if you believe in combined treatment, please don't do both on the same day. Yeah. If you do laser and then inject, the systemic absorption becomes more because you've broken the blood-retinal barrier. Okay?
At least 4 to 7 days.
And in bad case of AP, ROP, sometimes you may have to plan all the 3, laser, injection and surgery. So you know that child will definitely require all the 3. Yep, you have some question?
In case of non-compliant parents, so we inject and most of the patients do not turn up. Should we prefer deferred laser or should we go for second injections?
I think that is very important, I must say. In case the parents are not going to come back, you have to counsel them well. Anti-VEGF only after thorough counseling. If they are not and you have doubt, do laser in such a case. Otherwise, it's a problem because of course we did laser all our life, but in such a situation, laser is indicated. Anti-VEGFs can have a lot of issues if they are not turning up. They may come suddenly later on with all the problems and it might go to
also try to find if there's somebody closer to them who can take care. So we are having this issue. They'll fly from Delhi and say, you only should treat. When we tell you have to come 5 times, they say, no, we can't come. Then don't have that ego. Tell them, okay, there's a PGI, there's a doctor there. Please follow and to get the laser done there. So